we've got data, now we are driving evidence-based practice. But you're going to see now that more time has gone on, it's actually turned into a story about my journey of attempting to drive evidence-based practice using patient data. At the end of our time together, we're going to be able to discuss how specific rules were embedded into the EMR to track the types of documentation that proved as evidence of care that was delivered that helped reduce the incidence of hospital-acquired conditions or HACs. That's the end game of where we will be. So before we get started, let's talk a little bit about my home, Children's Hospital and Medical Center, because it is the best place for kids. And we like to say we're the best place because we're definitely a unique resource. Children's hospitals are only about 5% of the hospitals across the nation, and that's about 221. And of those, there's only 32 of us that are freestanding facilities. So we're always proud to pull out that little nugget of information that we're one of the 32 freestanding facilities across the nation. We offer a full-service pediatric health center of 50+ pediatric specialties. We're the only level 2 pediatric trauma center in our region, and we have a level 4 regional NICU. We serve about 500,000 patients annually, and at the moment we have 145 beds in our hospital. I say that because we're very excited to be launching at the end of August our new Hubbard Center for Children. It's a 9-floor expansion that's going to be about 460,000 square feet and an additional 100 new beds. So we'll nearly double our current occupancy. Those specialties on the screen, some of those are expansions and some of those are new for us. And so we're really excited about where the future is headed for our hospital and medical center. Here's our awards and recognitions. And we recently were received for 2020 U.S. News and World Rankings, 3 of the specialties as well. Here's the accreditations. And as part of being a pediatric facility, we do participate in the Solutions for Patient Safety, or the SPS network. And that is a network of 145+ children's hospitals that have a clear vision and a clear set of beliefs. But it's really through their all learn, all teach approach that I became intrigued with a webinar in late 2016 and was really the basis and the foundation for the project we're going to talk a little bit more on or in depth here over the next hour. So they have Aviator Wednesdays. SPS puts these presentations together, and this one in late October of 2016 that hit my inbox caught my attention because it had my buzzwords in the title of it: electronic health record, documentation, and analytics. I'm not sure how much more intriguing that could get for an informaticist. Additionally, I knew that Wisconsin Children's used the same EMR vendor, the same platform that we did. So however they leveraged their EMR and their documentation to produce this meaningful analytics, we were most likely going to be able to replicate the work that they had accomplished. So in their presentation, they shared the overall goal of engaging frontline staff, getting unit leadership and the microsystems to support that, and then ultimately having organizational support across their enterprise. And it was a lengthy journey for them, and a fact that they had stressed numerous times in their presentation. It was a culture change for them, and it was a 3-year evolution to get them where they were in October of 2016. Some of the outcomes that they shared had rather significant results, like $1.6 million in savings as a result of a 30% reduction in overall hospital-acquired conditions or HACs, and an elimination of serious harm through a variety of HAC reductions. And how they got that frontline staff engagement? Well, that was really a large part of the work that they obviously was focusing on the EMR and their electronic health record and the functionality that they could operate within that. So after hearing their story and seeing their outcomes, I reached out to them for some further collaboration and networking. And essentially what I was able to figure out through their partnership and their willingness to all teach, all learn approach was that I was essentially going to be able to stand tall on top of my own bus, a bus that I was going to be able to build and create based off of the lessons that they had learned along their journey and the way in which they were approaching this particular project for them. As we know, every good project or every good bus needs to have a title. So our title of the project was SAC a Hack, Tackling Hacks Using Data and Technology. Bit of a mouthful, so we ended up calling it HACK for short. Excuse me, Hack-a-Stack for short. To set the foundation, let's talk a little bit more about the hacks. Hacks are hospital-acquired conditions, as I've mentioned, and the SPS is focusing on reducing harm by preventing readmissions, serious safety events, and these 11 specific hospital-acquired conditions. It's through SPS's network of hospitals that each of these hacks has a bundle developed based on research and best practice evidence. And SPS then stratifies the bundle elements based on their level of evidence to assist the hospitals within the network in prioritizing their efforts so that they can design and implement these evidence-based bundles that are supported within each of those hacks. So our project, our SAC a Hack project. The objective of the project was to develop an electronic means that would allow our frontline staff two things. One, to be able to identify patients that were at risk for any hospital-acquired condition we may be looking at. And then two, allow them to identify the bundle elements that they had completed as evidence through the documentation and in alignment with the SPS bundles. So the scope, we needed some place to start, knowing we couldn't tackle all 11, we picked 4. The 4 we picked were based off of our organizational opportunities or needs, as well as ones that we thought would be pretty straightforward and ones that we could easily begin with or start tackling. So the 4 that we selected were catheter-associated urinary tract infections, or CAUTI, central line-associated bloodstream infections, or CLABSI, pressure injuries, PI, and surgical site infections, SSIs. So these were pretty lofty goals, and on the surface, it really sounded like things were going to be straightforward. It's going to take time. Yes, we were very well aware of that, thanks to our mentorship through Wisconsin Children's. But we didn't really think anything would be too difficult to accomplish. But as you all know, with most projects, you don't know what you don't know, and once you get going, you find out sometimes there's a whole different ballgame that gets dealt. So the team was myself. At the time, I was the senior PI informatics project manager, and I was the project coordination and implementation. We had clinical application consultants, and in our organization, they are the builders. They are the ones that work in the system and make the magic happen, if you will, within our EMR. The other people on my teams was definitely the patient safety coordinator. She served as a subject matter expert for SPS, the bundle elements, the bundle requirements, what those best practices were, and then the various hack groups that are stood up in our organization to help support the work of those hacks through SPS. So that was my content experts. I also had some sponsors, the Quality and Patient Safety Vice President, which is my Vice President, and then the Information Technology Vice President, CIO. They co-sponsored this project. The aims that we set forth to accomplish was threefold: implement 1 hack per quarter. We wanted to do and follow a plan, do, check, act, or PDCA cycle approach with each of the implementations, and then ideally see a potential reduction in the number of hacks. Knowing that this is just one piece of a complicated puzzle, we knew we wouldn't be able to identify and specifically, air quote, take credit of having these SAC a hacks be the true cause of reduction, but it should be one piece of the larger puzzle. The approach was to implement 1 hack per quarter, as we said in the aim, and then to do that through a series of PDCAs with each one of these implementations. So this is how we conducted our PDCA cycles and what we did in each of the phases. So in the planning phase is when we identified the bundle elements that we were able to locate in the EMR and determine what documentation supported that, both in terms of values and content, as well as the timing. Then the do phase was when we commenced and validated the EMR build. The check part was implementing the utilization, the reporting utilization within the EMR. to make sure that it was really capturing what we wanted it to and how we intended it to function for the end users, meaning the staff. And then the acting was evaluating their use of it to make sure that they were adopting and finding it to be as useful and as helpful in caring for their patients as we were anticipating. Our guiding principles led us through the process of evaluating those bundle elements. I talked about earlier with that hack slide. We needed to compare if a bundle element was even documented in the EMR, and if so, where that was. Could we even capture that in the medical record? Because sometimes a bundle may be very vague in what it is saying, like evaluate this. Well, we don't always necessarily document the evaluation of something. So we needed to really take a close look at that. So if we were able to capture it, and then where. So once we knew it was documented, an element was documented, we could then determine what documentation was going to indicate compliance. Was there something that was specifically needed to be documented? From there, knowing that it was there and what it was, then we were able to take a look and figure out the when. How often did that need to be documented? Then the last step of the principles was really staying true to the foundation of those best practices as they were laid out by SPS. But we also were cognizant of the fact that our subject matter group was going to be needed to help us align those best practices with our current aspects of our documentation. We really needed them to be the kind of the glue between the two sides of that.